Wow. The serial killer that lives next door. We just don't know when it will turn on us. That thought is going to, I think, stick with all of us. In any case, thank you, Discovery, and thank you to the filmmakers for sharing this film with us. Let's give a round of applause to Discovery and the filmmakers. Just a reminder, the television premiere of the series is a week from tonight. It's Thursday, March 29th on both Discovery and the Science Channel. And before I introduce a group of people who spend most of their waking hours grappling with invisible killers, I have a few very, very practical notes. First, we would love you to join the conversation we're about to have on Twitter at Atlantic Live. It's all one word, and use the hashtag #InvisibleKillers. And we want you to be part of the conversation in the room, too, so we will leave time for your questions. And now, I'm delighted to welcome Dr. Loring Flint, Chief Medical Officer at Inova. Dr. Loring. And someone we just saw on the big screen, Dr. Anthony Fauci, Director of the National Institute of Allergy and Infectious Diseases at the National Institutes of Health. And Dr. Inger Damon, a woman, I think her title is worthy of a TV drama. She is Director of High Consequence Pathogens and Pathology at the Centers for Disease Control and Prevention. And last but not least, my colleague, Steve Clemens, Washington Editor-at-Large for The Atlantic.
Hey, everybody. Have a seat, guys. Ladies, Dr. Strangelove.
Thank you.
You know, I was thinking when I was reading your title, because Margaret is exactly right. I just want to say it again. Inger Damon is Director of the Division of High Consequence Pathogens and Pathology, Centers for Disease Control and Prevention. And it does sound like a movie or a FX series or something of that sort. Do you get approached? Do you have anything going on the side that we ought to know about?
We actually get a hard time about the title. That's sort of a mouthful. So people say that we should be called the X-pathogens.
Excellent. Well, I don't know whether after a film like this, and I have to tell everyone, I watched all 3 of the Discovery segments today back to back, and I don't know if I wanted to say, wow, that was great, or whether we should all feel lucky that we're here at this moment to be alive given everything that's going on. And Tony, I want to jump to you for a second, because there is a kind of pat on the back feeling I got out of this segment on influenza, that in 2009 we only lost 450,000 people, and that's way better than 50 million, so we're making progress. Is there a kind of, is that the nature of grading success that we have to get used to? Because it seems it seems a little odd.
Well, no, I don't think this is a pat on the back that we didn't lose 50 million people this year. I think if you look at those of us who are involved in infectious disease and influenza, we really have a challenge that we need to do better, because we have a very unusual pathogen, as was described very adequately and skillfully on the film by the producers, that it's something that we have to keep up with. And I call it chasing after influenza. It's like every single year you have to make a concerted, hopefully intelligent guess about the vaccine. And unlike other microbes, other viruses, it changes so much. And I tell people, like, they said it on the film, that the measles that I got infected with as a child is the same measles that my children were vaccinated with, because it just doesn't change. So although it's nice that we're not having a pandemic, or that we are much better able to respond to pandemics, we still need to do much better on seasonal flu, because if you look, as David Morin said, the cumulative mortality of influenza over the years dwarfs many other infections.
Inger, I think one of the things that popped out in the film was just the casual way in which we talk about the flu. I think everybody in my office got the flu this season. I think I said I got the flu 2 or 3 times. Of course, we really didn't, but it's become part of our language and vocabulary. Do we need to rebrand what influenza or the flu to kind of restore gravitas to what we're discussing here?
Yeah, I mean, I think flu has become sort of a vernacular of any upper respiratory infection with fever and aches and pains. I think most people who have the flu know that they have the flu. It is much more severe, as was indicated in the film. But I think it's hard for people to understand what parainfluenza A, B, C, rhinovirus, RSV. All of these are sort of the influenza-like illnesses that we see. So I don't know if the influenza virologists would want to change their name.
Since you see, Ingrid, since you see and study and have an intimacy with the worst possible things in the world, what keeps you up at night? What do you worry about?
So I think what keeps me up at night is what we don't know. We're fairly good at this point in terms of rapidly responding to new diseases as they're described and identified. We've developed really good tools over the last 10 years to, whether it's next generation sequencing or these types of approaches to rapidly characterize new viruses as they evolve. MERS, I think, is a fairly good example. It was much harder to understand how that virus emerged in the human population, and that took more time. And so I think these zoonotic diseases, in terms of what do we have to worry about in terms of what we're seeing in animals, which of these may emerge in humans? We heard that discussed in terms of influenza as well. So I think right now we have a fairly large occurrence of Lassa fever, which is a hemorrhagic fever, individuals with bleeding disorders, high fever. It's from contact with rodent urine. There's common seasonalities, but we're seeing more of it now in Nigeria, and there's quite a response. So we wouldn't necessarily have predicted this much larger occurrence. There's sort of a baseline occurrence. And so understanding what's happening that's leading to that is really important.
Are we going to do better next year on flu vaccines?
Well,
Tony?
unlikely. As I said on the film, that a good year is a 60%. But we have to be careful because even though one of the characters said that although the numbers might not be great, like measles and yellow fever vaccines, which are highly effective, the amount of lives that can be saved even by a vaccine that's modestly effective, you could prevent 50% of the deaths and the hospitalizations that you might see by taking the flu. So the thing that we always say correctly is that it's always better to have some degree of protection than to have no protection at all.
Lorraine, if I were to characterize Inger and Tony as on the whole side of invisible killers, you're on the retail side in the hospital business. And I'm interested as you think about your clients, your communities that you work in. I'm very familiar with Inova, as you know, we've been friends for years. And as the healthcare system has been put through all these knots and changes and challenges in recent years on what wellness means or what fee-for-service means or whether you have a lot of beds or you don't have a lot of beds. When you see something like this and you experience the front end of a lot of people, and more people this year than in previous years who are suffering from influenza, how do you make it through that? What is your approach when you think about serving your community where they're at, given the fact we're in Washington and Washington is changing the very structure of how healthcare is delivered?
Yeah, so it's a great question, but I think what we think about is first, what is our capacity?
Right.
So as it relates to how many people are showing up in our emergency urgent care centers, do we have to staff them differently, particularly during a peak season, which we did in January, early February, when we had a lot of people walking in.
Can you give us your numbers? How much at capacity were you?
No, we probably increased by about 20% in just the walk-ins, urgent cares as a way to just make sure people were not waiting. And then from that, how many people needed to be hospitalized. And surprisingly, even though the prevalence of flu-like syndrome in Northern Virginia was very high, the number of people who got hospitalized was not that bad. So we had overflow in the emergency rooms, particularly at night, but by 10 o'clock, 11 o'clock in the morning, everyone was able to find a bed, which we were surprised at because we were preparing as we're watching what was going on around the country as to whether or not do we need tents. Did we need to open up old areas that used to be hospital beds that were now mothballed and be able to handle a surge. And fortunately this year, that did not happen as far as hospitalized patients. So it was a very, particularly in Northern Virginia, very active flu season, but mostly people who were okay, were able to be treated in an urgent care or doctor's office, emergency room, and be able to go home.
You know, one of the things that I thought about, and Inger, I know that you led the country's response on Ebola, CDC's response on Ebola. And you were in I know you folks haven't seen this, and I don't know from the Discovery folks when these other shows are showing, so I hope they've told you, because definitely watch all three. But the one on Ebola, where you were in Sierra Leone and Guinea and, of course, in Liberia, and visited these, let's just say it wasn't there. Let's just say it was Northern Virginia. How does the system out there, the interaction of the system, you had to build infrastructure in Liberia, but should we feel all kumbaya and happy that we've got Inova over there? Are they completely prepared for an Ebola-like thing and the disciplines they have, or do you worry about them being able to handle and manage something like that?
So I think we learned a lot during the Ebola response in terms of how we really think about domestic preparedness. I think we focused a lot internationally on what we needed to do to prevent disease in Liberia and Guinea and Sierra Leone, to prevent disease from spreading. It certainly was a challenge in terms of finding sufficient partners in country to help with these efforts and train local physicians, local healthcare workers, of which there were really quite few, especially in Liberia. So I think in terms of turning to the domestic response, I think we made decisions. We moved out through the state and local health systems to sort of implement some of the actions that we recommended. We had to review these decisions constantly and make changes. I think we had a tremendous burden that we put on our domestic healthcare system to be prepared. And I think there's an enormous appreciation of hospitals that stepped up and said, we'll be what's called an assessment hospital. If there's somebody who we think has signs and symptoms that could be Ebola,
Right.
we will train our healthcare staff, we will get certified, we will have the right PPE, we'll train them and make sure that they know how to work safely with these individuals, what should be done, how to be triaged.
So is that a long way of saying that they're okay, or that you're worried?
I think what we learned is that for any new pathogen, you need to make sure that people at the local level are thinking about it and practicing and training.
Loring, are you thinking about it and practicing and training?
Well, I would say with Ebola, it was a very interesting crisis because, as you know, we're at the crossroads of two airports. And so with that, we knew that there was a strong probability that somebody might be coming into Dulles and be potentially screened positive, and how could we be ready? So we really worked very diligently to make sure we trained our staff on protective practices, what was going on. We actually rebuilt a new unit to get ready just in case we had too many cases going into the National Institute of Health, at which point we could be an overflow area. So we're constantly training, but what was fascinating was the press knew more than we did. They were calling me saying, oh, there's a patient going to be admitted at Loudoun, and we're chasing him up the road. So with that, we were constantly really chasing the information age as it related to how ready we would be. But whether it was Loudoun Hospital or Fairfax, I think we really had a number of cases that were screened, and with that, fortunately, screened negative. But we had to be ready, and the constantly changing guidelines was a lesson for all of us that nobody is perfect with a brand new disease. And so how the training had to change, how we continue to protect people as the Ebola crisis really continued to evolve. What we learned from Texas that we could apply across the country was really a wonderful testament to the real leadership that was provided by the agencies, the CDC, NIH, as it related to making sure we could all be ready. And a lot of patients, as it related to the recommendations we had 2 weeks ago, were not the same ones today, but we had to accept that and move forward.
So let me ask you a zinger question. I'm going to then go to Tony and put this all on him. But because the third segment, if you really want to get scared, is about smallpox. And it's not just about smallpox, but it's about vulnerabilities. It's about bioterror. It's about the potential that an evil person with not very much money could come together and potentially release something that the world had thought it wiped out. Stockpiles were kept in the United States and Russia, and maybe they're in a few other places. But if you were sitting in one of your Nova hospitals and your doctor came up and said, I think I have a case of smallpox, what happens? What happens in Inoma on the retail side of this? What do you do?
Well, immediately, if we had that concern, we would isolate the person and isolate the staff. So make sure they were in a private room, they were using the ultimate of protective equipment, and and then we call the NIH. And we sit down and immediately say, hey, we think we have this, what's going on?
You don't call Inger or Tony?
You know,
Yeah?
we probably call
Yeah,
Tony or one of
okay.
his associates and really
Yeah.
sit down and say, wait a second, here's what we're thinking. But we had that example, as sad as it is, measles is uncommon today. So, you know, literally missing a case of measles, thinking it's a
Interesting.
Coxsackie virus, and all of a sudden creating an epidemic because we might have an immigrant who is not exposed to the measles vaccine or decided not to get immunized. We have that type of situation because these are not common diseases. Fortunately, we're close to DC. We have phenomenal resources to be able to support us.
Tony, at the end of one of these segments, and I've forgotten which one it says, you said the thing you've learned is we need to prepare for before outbreaks occur rather than just reacting to them. So my question to you is, do we have enough to prepare for the outbreaks before they occur? Do we have enough to prepare before a potential re-engineered terror attack that might yield smallpox or the next lurking avian flu virus?
Well, we will not ever be able to stop an outbreak of a new disease. But what we hope to do is to prevent that outbreak from becoming a widespread epidemic or pandemic. So when you say, do we have enough? Steve, I don't know what you mean, enough what? I mean, one can...
I was giving you an opportunity to ask for more resources
Yeah, well-
publicly. I like you. Can only lead a horse to water.
Right. Well, we just got $3 billion more today in the budget, so that's pretty good. No, the issue is that there are ways of preparing. For example, if you want to have a vaccine, it's very, very difficult the way, for example, we respond to influenza. If you had an outbreak of influenza and you had to make a new vaccine, we had that experience. Luckily, it was not a terribly deadly flu, but the 2009 H1N1 first pandemic of the 21st century. We knew in April that we were going to get a flu pandemic the following winter, April of 2009. And we knew that 2009, 2010. And we put into place the process of making a vaccine, which takes the way we do it today, is mostly, not completely, but mostly growing in eggs. And it takes about 6 to 9 months to do that.
Right.
So we started making it thinking that we would have enough vaccine as the winter started in November and December so that we can vaccinate people. However, the flu didn't wait for us. As soon as the children came back to school in September, they all had the outbreak. So as the cases went up and then started coming down, then the vaccine became available. So that what did that tell us that we've been discussing a lot with the CDC and ourselves in FDA? We need to have a much better way to make vaccines. We need to graduate out of the antiquated technologies and get more recombinant DNA technologies that you could rapidly respond, where you don't have to worry about growing a virus. You can just sequence it, which most of us, including Inga, can do in a day or two. And then when you do get that sequence, pull out the gene that you're interested in inducing a protein to make a response again, and you could really dramatically truncate the amount of time that you can prepare. So do we have what it takes? We have the technology, we just need to implement it a little bit better.
You know, one of the things that struck me about the film, when they killed all of the chickens in Hong Kong, C.H. Tung, the chief executive then of Hong Kong, you killed all the chickens in Hong Kong. And I'm sitting there saying, we're thinking about those pharmacological approaches or scientific approaches to dealing with this. And I'm just wondering, why don't we just shut down some of the markets? You know, why are we continuing to have havens where very clearly you have repeated problems of human contact with animals in constrained and confined circumstances? Why aren't we somehow putting some effort into that, or are we?
No, we are. We are doing some of that. But as you said, why don't we shut down the markets? If we had shut down the markets in 2009, it was a pig virus.
Right.
So it depends. What do you want to shut down, the pigs, or you want to shut down the chickens?
I'm ready to go just vegan.
Right, and I think there's
yeah.
also an enormous amount of economic impact that you have to think about in these situations. And so I think the decision that was made in Hong Kong to sort of kill all the birds in the market was an amazing economic investment in terms of a hit that all of these farmers, took in terms of their livelihood. So those issues are always going to be part of it as well. And to go back to the smallpox issue, smallpox is one area where we probably need to do some additional work, but there's actually been a good foundation of work in terms of training, a rash illness algorithm that the CDC has on its website, available resources to state and local health departments and epidemiologists to do testing, to screen for it, and how to think through a potential diagnosis. But again, it's sort of that issue that unless you train for it and people exercise through it, they don't necessarily have the muscle memory to actuate a response.
But Ingrid, I mean, I'm watching up there. Craig Venter's one of the interviewees in some of these shows, and he's the guy who, decoded the gene and DNA, and what we saw when this, again, I know some of you haven't seen this, but a cowpox, am I right? A cowpox strain was recreated.
Horsepox.
Horsepox, excuse me. Out of a mail order access, a guy spent $100,000, a scientist, showing that you could re-engineer a virus of that sort by ordering segments of DNA from various places, and then wrote about it and said, we're vulnerable. And I assume you're a national security type for everything you know, right? And all that. So do they call you and say, how do you keep this from happening?
Actually, I was part of the WHO panel that sort of was convened a couple of years ago to say, with the changes in synthetic biology capacity, is it possible that somebody could recreate smallpox virus? And the consensus of the experts who were there, and it was essentially 5 pox virologists, including myself and a number of public health experts, was that, yeah, at this point in time, with the technological advances, it is possible. And then horsepox was recreated. So I think it's a wake-up call in terms of just thinking through, it's yet another indication that we really do need to be thinking about this and making sure that we have some level of preparedness. And so I think the US has invested in terms of antiviral development, in terms of vaccine production, stockpile, also vaccine evaluation for a less reactogenic vaccine. So many people who got the historic smallpox vaccines that probably all of us got as children, which were sometimes associated with severe adverse events. And so individuals in our population now with severe HIV may not be able to take those vaccines, and so trying to develop ones that could be used more safely in some of these at-risk populations.
How much of your time is fighting people who don't believe in your science?
I don't know if it's they don't believe in the science, but they don't necessarily believe in the risk, the potential public health risk. And I think that's more the communication, is how do you balance that potential risk versus the actual risks that we see now in our society, whether it's HIV, whether it's tuberculosis, some of these other diseases, whether it's the opioid epidemic. And so it's really balancing.
Do you think the best way to solve the opioid epidemic is the death penalty for dealers?
It also involves infectious diseases, so.
Yeah.
But Steve, the important point when you're dealing with infectious diseases that
Right.
you're trying to prevent, it is very, very difficult to get people excited about something that hasn't happened.
Right.
They always get excited about when it does happen, but when you try to get resources and interest in things when you're trying to prevent them, and we know that when we go before the Congress and we talk about the preventive things, but when we have an outbreak, then we get all the support you want. But when you go and say,
Well, you need to go show them these shows.
yeah, well, maybe
Because
we
what's
should.
interesting in these
Yeah,
shows,
we
it's
should invite
happening
them,
all the
yeah.
time, right?
Right.
The graphics are always there. The tsunami of connected, pathogens being passed on, whether we all suffer or not. But it's amazing to look at those graphics and how you've done it. Let me ask you both before I go to the audience. I had the privilege, really was a privilege, to interview Vivek Murthy, the former Surgeon General, a couple of times, and one time Elmo popped out. And the notion was to try to communicate with children about the importance of vaccinations and why it was so critical, because what was happening, at least in the sense of his office, was that more and more parents were being led to believe that vaccinations might lead to autism or other sorts of problems, health problems. And so they're trying to reach children to kind of create that pressure out there. And I'm just wondering what the state of that is, because that's another big part of the loaded nature of this important message that we saw on the show, which is vaccinations matter. I mean, maybe that ought to be the slogan, vaccinations matter. But how do you both see the terrain out there right now regarding public attitude on vaccinations, and whether or not more and more people are taking themselves out of the system?
I honestly haven't seen a lot of that pushback. But what's interesting is the cultural change of when we mandate vaccinations, how much resistance we get. So, we mandated now 4 years ago, every one of our employees had to be vaccinated for influenza. 17,000 employees. You'd be surprised how each year there's a dozen people who say, I'll lose my job rather than be vaccinated just because they want to be a free spirit. Same thing with the medical staff. They don't want to necessarily tell us they've been vaccinated. They want to keep their autonomy. At the same time, they've vaccinated everyone in their office. So I think there's a very interesting cultural change as it relates to people know there's good public health, but they don't like somebody, Big Brother, telling them you have to do it. So I think that's been an interesting twist, and one that is a continual fight as it relates to just how do we make sure anyone walking into an Innova facility knows all of the staff taking care of them have been vaccinated against measles, chickenpox, rubella, as well as influenza annually. It's great public health, but people want to fight us.
I want to line up for another smallpox vaccination.
No, you don't. No, you don't.
Tony, how do you say? Because I know you were very active in this discussion about vaccinations, and you were worried.
Well, I was, because there is clearly more in certain regions of the country than in other regions an anti-vax feeling about people not wanting to take the perceived, and in most cases the non-realistic risk of a vaccine compared to the risk of a disease. And we see that particularly with the measles anti-vaxxers. And the problem with that is that reticence to get a vaccine for measles is fundamentally based on false data that was propagated years ago by a physician in England who connected measles vaccine with autism, which was absolutely not the case. It was fraudulent, and the person was essentially debarred. Yet that lingers, this idea that the risk of the vaccine is so great that you don't want to get a vaccine. Now, if everybody felt that way, then we'd have measles outbreaks, which we already do have pockets of measles outbreak. And I think what people don't appreciate, and it's sort of a victim of our own success in vaccinology, measles is a very serious disease. It kills tens of thousands of people throughout the world each year. We are very fortunate that we don't have measles, yet when you don't see measles in society, parents say, well, why should I have my child vaccinated? There is that in this country, and it's unfortunate.
Okay, I'm going to go to all of you. Are we going to turn on lights so people can see? We can see you guys.
And I think that's another great example.
But really quick,
of just
Tony, I want to give Tony credit for something else people may not know about him. He is one of the real heroes in the HIV story, who changed the pathway for drugs to essentially get to the people who needed them, move that in a much faster direction. And Tony, I want to ask you a question. What is your next thing that you need to fix in the healthcare? So what is still broken that you in your tenure haven't been able to fix?
Well, I'm not so sure, Steve, that we're going to be able to fix it, but I think we've spoken about some of the things now, and I think that this film actually highlighted that we really need to do better with influenza. We have to. We have the technical capability of doing it, but there are still some scientific obstacles because flu is really a very elusive type of a foe. So for influenza, you asked Inga, what keeps her up at night? What keeps me up at night is a respiratory illness that has the capability of spreading well from person to person, and that has a high degree of morbidity and mortality. Remember, the mortality of flu is very, very low. It's less than 1%, a fraction of a percent. If you could get it to 3 or 4 or 5%, you'd have a disaster on your hands.
And that's what happened in 19?
Well, it was only 1 to
19 or
2%
something.
mortality, as
Yeah.
it was shown on the film, and still 50 million people died.
Wow, wow. Okay, yes, hi. Greetings.
Hello.
Who are you?
My name is Rebecca. I have a question about antimicrobial resistance. Should we be worried about pandemic influenza and secondary bacterial infections interplaying with antibiotic resistance?
Antibiotic resistance. Who would is that a?
Well,
Yeah.
Well, yes, we should be worried about antibiotic resistance because it is a problem that is.
Scale of 1 to 10, how much worry?
Well, you know, I don't want to have the other diseases get angry with me. It's a serious problem because we do have certain pathogens that are now becoming
This
resistant.
could be like Shark Tank, you know?
So the answer is that yes, you do get secondary bacterial pneumonias and infections in influenza. And generally, you know, they could be staphylococcal, they could be Haemophilus, they could be pneumococcal. Most of the times we have antibiotics against them. But there are certainly a number of pathogens in which we have relatively few, not complete, but relatively few, particularly the gram negatives, such as the carbapenem-resistant antibacterial.
Anger, scale of 1 to 10, your worry about? It's a number.
I don't know, 3 to 5.
There, Lori?
I'd probably say 3 to 4.
3 to 4. Okay, there you go. You got 3 answers there. Yes, in the very back.
Hi, my name is Michelle Daly. I have a friend who had apparently an adverse reaction to a vaccine. It was not a flu vaccine, but she was experiencing dizziness, headaches, etc., and muscle pain. And in the course of that, she started researching side effects and discovered that a lot of vaccines routinely have heavy metal contaminants in the vaccines. And I'm wondering whether or not you believe that is true, and if so, whether there are any adverse side effects
Thank
to
you.
that.
Tony, you look excited by that question.
No, that's really unfortunate. That is a myth. It's not the case. I think when people refer to so-called heavy metals, they refer to some multi-dose vials of influenza and others have thimerosal in it at such a low concentration, and besides, it's ethyl mercury and not methyl mercury. So it's a situation where it is not true that they certainly could have a reaction to a vaccine because no intervention is without risk, even though it's very, very small, but it's not due to the heavy metals because they are not in the vaccines.
I know you have the mic, but I was going to go to the gentleman with his hand on his forehead right there because you look like you were getting ready to bid at the auction. Yeah, no, yeah. I'm just joking. He's turned away. Yeah, you. I was going to go to you. You look so thoughtful. Yes, but you've got the mic. Go ahead.
Hi, I'm Lily Kahn. I'm here with my infectious disease colleagues at NACHO, representing local health departments. So we've really appreciated working alongside CDC, responding to H1N1, Ebola, Zika. And so for better or worse, we've gotten in this habit of knowing the first 3 steps we need to take to organize ourselves when we're a part of a response for the unknown. So I'm curious from each of you, having been a part of these responses, what are the first few things from each of you now in kind of bracing yourselves and kind of about to go into the unknown when an event happens?
Yeah, like what happens if an H2N7 hits, whatever that may be?
How about 8, 7, and 9? How about
Okay,
8,
there you
7,
go.
and 9?
Go ahead. Yeah, please.
Well, I think you should start with the CDC because the CDC are really the disease detectives.
Yeah,
They
yeah.
are. I mean, they're the ones that do the
You're the front
surveillance
line.
and identify it. Yes.
Right. So I think the first thing is sort of taking a deep breath and gathering all the information that you can in terms of what's going on, in terms of the epidemiology, what's the characterization of the disease, do we have the right specimens, how do we quickly identify what this is, and that's going to be a combination of efforts, whether it's tissue culture, growing the organism, sequencing it, characterizing it otherwise, electron microscopy. And then looking at what tools we have that are available, what's not available, and then making sure that as soon as we have an idea of what it is, making sure that the outside community, public health community is aware, as well as the clinical community, so that people can then take action and putting guidance together.
Thank you. Let me go to Lauren.
Yeah, I think our concern would be how do we keep all of our employees as well as all the public safe. So the first thing we'd be wanting to do is make sure anyone with the presumed new whatever basically was isolated. and starting to isolate that person, make sure that we could minimize as much as possible any cross-contamination would be the very first thing we'd do, as then we'd find out more as to what is the pattern of contamination, how is it spread, what's going on, and how do we ensure that we're able to get early treatment. But most of what we'd be doing as providers is supportive therapy initially, making sure they don't get dehydrated, make sure that they're eating calories or whatever, and some of the basic things to just keep people alive during the unknown.
All right, Tony?
Yeah, well, the job for the NIH would be to develop an intervention. So, for example, as Inga said, and let's use H7N9 as the prototype, which we are responding to the possibility that might turn into a pandemic, is to develop a vaccine and to test it as quickly as possible. Make sure it's safe, make sure you have the right dose, and test it in the appropriate people. Right now, we're testing it, and we just started it literally a week or two ago in healthy adults and in elderly. And when we get the right dose and the right dose combination, then you could just pull the trigger and make enough vaccine in case there is an outbreak.
We have one more, two more. We've got a couple. I've got a couple of minutes, right? You guys don't want to drink yet, right?
No,
So,
we
go
got
ahead.
our drinks. So Larry Schoen, American Society of Heating, Refrigerating, and Air Conditioning.
It's almost as, that's another Dr. Strangelove title.
Right. And we do standards for
Oh,
the
sure.
built environment. We don't do vaccines.
Right.
So,
But ventilation matters.
yes, well, so that's my question. We're writing standards, we write codes that become part of the built environment for buildings like this, bus stations, train stations, movie theaters, places where people congregate. We can influence things like ultraviolet germicidal irradiation, filtration, airflow, and so on. Does what we do matter?
Great
And
question.
what should we do?
Of course. Yeah, of course what you do.
Scale of 1 to 10, how much
No,
does he
I mean,
matter?
when you talk about diseases that, for example, are spread by respiratory, and one of the best ways to do that is to have better airflow in enclosed places. That's the reason why an airplane is probably the worst place to be during a respiratory disease outbreak.
I mean, that'd be a business, is putting irradiation systems into the ventilation of airplanes, right? That would be good. But I think, just as a side comment, I think what you said is so important, because I know that things like Legionnaires and others were very much a part of the question of having ventilation systems that didn't have the kinds of things you were talking about. Do you have any thoughts on this, Laurie?
Yeah, I'd say, I mentioned a measles case that we had 3 or 4 years ago, and it was in the oldest part of our hospitals, and we were recirculating the air. So do you make a difference by making sure that you're taking care of the air quality and making sure it's being ventilated outside rather than internally? It's huge. And so for all of us, it was a wake-up call.
Can we, and then can we get a mic over here real quick? Yes, right over here. Are you going to ask her? Go ahead.
Sorry.
She's not going to let you have the mic.
Okay. I'm Ritika Bardwaj. I'm from Spectrum Science Communications, and I have a question regarding this data collection and deciding which flu vaccine needs to be made. So it looks like there's proactive data collection, and there's data collection from hospitals and all across the world. Can that be made better with better diagnostics or better way of collection? Are we perfect in that sense? I'm
Great
assuming
question.
not, and how can we make it better?
Great question. And Christine, if you can run to this gentleman, I think who is over there. Or he moved. Oh, he moved there. Okay, not yet, but data collection, data analysis, is it as good as it should be?
Well, the question asked, is it perfect? It's certainly not perfect.
I said, is it good as it should be? but,
Well,
yeah.
no, I mean, we could always do better. Generally, the match is usually good. You get hints from what they had in the Southern Hemisphere the season before, what you had at the end of your season. That's exactly what we saw at the end of the 2008-9 season. We saw these things. And you have people from the various WHO coordinating centers. They get together and they make a concerted guess. One of the problems with influenza is that the time frame that it takes once you push the button and say, let's start making the vaccine, that the virus can actually start to mutate. And occasionally you get a mismatch where you say, we're going to go after this one. You start making the vaccine, and then what happens by the time you get to the full production, the virus is a bit different. And we've seen that.
I hate giving away the story in the film, but you need to watch the episode on Ebola, because when you think about data collection, they're going into these deep jungles, your people, and they're getting samples from fruit bats and critters of all kinds. It's a very different kind of data collection. I was so impressed with that. I assume you're involved in that fruit bat collection
We are.
process.
So
We are, the big we.
That's right. Well, yeah, members, I mean, there's a number of organizations involved in terms of doing surveillance, in
Right.
terms of wildlife surveillance to understand where these diseases are. So our group has really looked quite a bit of work on Marburg virus in terms of taking the surveillance data and the epidemiologic data and then moving it actually to the lab environment to ask specific questions with these bats to understand how humans may become infected. But I think to your point, it really is, the surveillance is pretty good in terms of what's being looked at in terms of influenza viruses across the world through the collaborating centers. And it really is this issue of this period of time when the viruses can change between when the surveillance is done and the vaccine is finalized.
Loring, is Innova a data sharer or a data hoarder?
I think we'd be a data sharer as it relates to what we're seeing, how we're moving forward.
That's
and-
tweetable, I guess.
Okay.
Last
But
question
Steve,
from this
just,
gentleman here. And with all of the other questions, we'll hang out and have drinks and be able to do that. But the last question right here, sir.
Good evening. My name is Max Brooks with Discovery Education. We actually work with over 50% of the schools in the U.S. and over 65 countries internationally. My question is for Ms. Damon. We've learned a lot tonight about just the generational evolution of all these viruses, but as a woman who's in the STEM field, so often we find out and talk about the pipeline just draining for young women
Right.
interested in pursuing that field. What advice would you have, and how did you get to where you are, and what advice would you have for young women who are interested
And I
in
want
the
to hear
STEM
this
field?
story, but in short form.
I don't know. I think I was the kind of person who always liked solving puzzles. I had two parents who were both scientists, and they certainly encouraged my interest in the sciences. They weren't too sure about me becoming a medical physician, but
Since that was so short, there's this gentleman that looked a little frustrated when I didn't ask him here. I'm going to go to you because you really communicated very well. No, we got to get a mic because there are lots of people watching online. So here we go. Bring your microphone. And then we'll wrap with this and then go to the bar. We're in the Hamilton. Yes, sir.
Oh, we're going to wrap? Can I just ask the question? A comment and a question, okay? The
Yeah.
comment is, now that Ozzy Osbourne has passed away, heavy metal contamination is no longer a problem. Okay. Question.
And the question.
Question, okay? Suppose that there is an outbreak of an influenza that we have not anticipated.
Yes.
That the vaccine is minimally or totally ineffective. Given that it takes 6 months to develop a vaccine, and given the exponential growth of pandemic, what recourse do we have
Right.
to containing that pandemic?
Thank you. Tony, I'm going to throw that to you.
Well,
Doomsday.
Well, that's a very difficult situation if you don't have a vaccine, or as the scenario is, by the time you're getting the vaccine, the flu is already spreading. There are a number of things you could do. Social distancing is one. That's a very, very important thing. Avoiding crowds with regard to schools, going to theaters, going to places where there's this should not happen if we were in the middle of a pandemic. So social distancing is one of the most important things that you can do.
Any quick thought, Loring?
Just as was mentioned, social distancing, good hand washing, masks to make sure that you're stopping, if it's a respiratory piece, that you're stopping the droplets moving forward, making sure you're using tissues rather than handkerchiefs, and washing your hands. Simple public health issues.
I think we should all go to Japan and learn how to bow. With that, we've had a wonderful conversation. Thank you for the stimulating, mind-stretching thoughts. Great audience. And I want to have us all give a big round of applause to Inger Damon at the Centers for Disease Control and Prevention, Anthony Fauci of the National Institute of Allergy and Infectious Diseases, and Loring Flint with the Innova Healthcare Systems Innova. Thank you so much.
And thank you, Steve Clemens, Doctors Damon, Fauci, and Flint. And thank you, Discovery, and the filmmakers. Let's give one more round of applause. And I also want to thank you who have been here in the audience. I hope you leave here feeling smarter about viral outbreaks and the urgency and complexity of these issues. You deserve a cocktail. The drinks will be free-flowing. There's coffee. There are petit fours. So linger a little longer with us and enjoy one another and the rest of the night. Thank you all so much.